Joining us for another session of disease prevention and well-being. My name is Nancy Mourad, and I'm the head of disease prevention and well-being at MetLife for the Gulf region. And today we're gonna talk about what else than the topic of breast cancer throughout the month of October. And with me, I have Dr. Elias Abi Khalil. Dr. Elias is joining us from Dubai, right out of his clinic in Clemenceau Medical Center. And we're going to talk today about, of course, we have talked a lot of the times, about early detection and prevention. But also we will try to focus with Dr. Elias about things that we need to keep an eye on after breast cancer. So really maybe a big statistic here that we always forget about is that 1 in 8 women in this world are susceptible to getting breast cancer throughout their life. So before I give it to you, Dr. Elias, a brief intro. So Dr. Elias leads the Department of Gynecology at Clemenceau. He's American Board Certified. He is definitely the specialist of advanced pelvic and robotic and non-invasive surgery at the hospital. He comes from years of experience at George Washington University in DC, and he's been in Dubai for a few years now. Dr. Elias, the floor is yours. I'm really excited about what you have to share with us. As usual, guys, we're gonna cover points over a few slides, but then it's gonna be all about your questions and everything that you may think about, whether breast cancer or other reproductive and women health areas for today. You can share your questions via the chat or the Q&A. I'll be taking them, and we will come back with a Q&A session after this talk. Elias, to you.
Thank you, Nancy. Thank you for this introduction. Hello, everybody. It's a pleasure and an honor to be with you. I hope this session will be a little bit educational and a little bit of kind of an awareness about a really, really very, very common and it's not one, it is the leading cancer in women. So that's why it is very important to raise awareness about this. So basically, breast cancer as Nancy said, affects 1 in 8 women. That's a very common disease, and it's really an event that alters a woman's life. That's why I'm gonna stress more today on what is life, how is life going to be after breast cancer? Because everybody keeps talking about the treatment and how to detect it. I'm just going to mention a little bit what should we do to prevent breast cancer. And really early detection is key in this disease, because the earlier the stage of the disease that you catch it in, the higher the cure rate and the lower the recurrence rate, and basically lower the treatment period. So that's why we keep, having awareness about having screening for women. And the screening should be categorized as follow, okay? In a low-risk population, which is the general population, someone who does not have family history, someone who has not had previous radiation on the chest, someone who does not have hereditary gene mutation that might predispose them to breast cancer, then basically these are low risk general population, and we start screening at the age of 40, okay? Some societies recommend screening every year, and some societies recommend screening every 2 years after 40. And then starting at 50, everybody aligns to screen yearly with mammograms. Now, usually the screening should be with mammograms, and then ultrasounds are an adjunct for the mammogram for the screening, especially if you have dense breast, then this is where an ultrasound is usually recommended. However, in this part of the world, we do ultrasounds on everyone because really they're not you don't have exposure to radiation. Ultrasonic waves are non-harmful for the breast, and it gives the radiologist a more reassurance that everything is fine and double checking what they found on the mammogram. So that's why it is done in this part of the world. Usually the mammograms are the one that are annoying because these are the painful ones, but the ultrasound is the nice one to have. Now, anyone with who is a little bit high risk, okay, and we categorize them as high risk, which means they have high family history risk, someone first degree relatives, mother or siblings, or multiple second degree relatives. These are the high risk people, and you have the high risk, which are the people who test positive for gene testing. The most common are BRCA1 and BRCA2 gene testing. So, and this is based on the lifetime risk. This is how we categorize people. So low risk, medium to high, and very high risk. And it depends on a model that we have. It's an algorithm. It puts the age and multiple factors and gives you, it's called the gain model. And it puts you into the categorized risk. And based on that, we screen for people. So probably most of you are going to be in the low risk, which is screening every 2 years at 40 and then after yearly after 50. If someone has significant family history, then they usually start with the earliest age that a first degree relative was diagnosed, and we start 10 years earlier than that screening, okay? And then if people have the BRCA1, BRCA2 gene testing, which they have a lifetime risk for BRCA1 around 60 to 70% of breast cancer, and BRCA2 around 40%, these people have a special detection screening, which is alternating MRIs and mammography starting at a very early age, okay? And these are the people that prophylactic mastectomies are offered for because of their high risk, okay? So this is how we screen basically for breast cancer. Now, what we're going to focus today is what happens when, so briefly, what happens when you're diagnosed with breast cancer, okay? Basically, most of people will have surgery, okay? And the surgery will entail either removing the lump that they see or removing the whole breast on one side or removing both breasts on both sides. So, and the surgery usually, when you have lymph nodes that are involved, the axillary lymph nodes that are right over here, usually you require, and depending on the size of the tumor, you're going to require chemotherapy and radiation therapy, and that is decided by the oncologist. And usually this is started within a month of the surgery, okay? The chemotherapy timeline is somewhere around 6 months, and the radiation is going to be somewhere around a couple of months. So I'm just mentioning these because for people to know what is the timeline that they're going to have to go through after surgery. And then also breast cancer, there are two types. There are two types that require additional medication. We call them the endocrine therapies. And then these are if they're hormone responsive. So we call them estrogen or progesterone receptor positive cancer, or if they're hormone non-responsive. And there's a receptor called the Herceptin receptor that we have now targeted therapy against. So people who test positive for that will have to have this targeted therapy, and it's called trastuzumab. Okay, so basically, if you want to think about it, surgery, then 2 months of radiation, 6 months of chemotherapy, trastuzumab for around 2 years, a year to 2 year, and then within this you keep taking the tamoxifen for 5 years approximately. So tamoxifen is for breast cancer that are hormone.
Yes, sorry to interrupt you. We're still seeing the today's focus slide. Are you by any chance, did you
Yeah,
move
yeah,
to
I'm
the
here.
next one?
I'm here. I'm still here.
Okay,
Yeah,
good.
yeah. So this is the timeline. So you want to think about it that surgery, intense therapy for 6 months, then minimal therapy, but it's going to last up to 5 years. That's how long it takes to really get over breast cancer. And after these 5 years, you need at least a couple of years of, recovery. So first, psychological counseling is very important. And sorry, yeah, you're right. I didn't go through the slides, but there I have them here, what I was talking about, okay? So it's very, very important for us to psychologically counsel a patient on what is going to be the path and have someone that is close to them, whether it's going to be a psychologist for psychotherapy or it's going to be a psychiatrist that helps them with, medication to keep the mood in general better and keep the positiveness through this whole, journey. All right. Now, also this journey is gonna get through, you need to post-treatment follow-up. So we need to follow up with to make sure that there is no recurrence of the disease. And that follow-up, that we have different protocol on how to follow up, but usually is after they're done with their episode, you need to do a clinical breast exams every 6 months and with adjunct either mammograms or MRIs. And these will at least for the first 2 years, and then we can space up until we hit 5 years, and then we can go back to regular screening because really the highest risk of recurrence is the first few years. So that also is going to be within these 5 year period. So I talked about these endocrine therapies, and these basically are very important to decrease the risk of recurrence. Okay, most of these endocrine therapy are gonna end up putting the ovaries at rest, and this is gonna create some of the early menopause effect. So that per se is another thing that we have to keep in mind. What are these therapies for 5 years? What effect they're gonna have on your body or on someone's body? So that's why psychological counseling is important. Also, someone to tell you what is the path during these 5 years. A very important thing is genetic counseling because we know that 10% of breast cancers are hereditary and there are many genes involved. So it's not only BRCA1, BRCA2. These are the most famous because of Angelina Jolie, but there are other genes involved there. And really, genetic counseling is very important because someone needs to look in details at the family history and they need to be tested. Even so we test in two ways. Either the tumor itself can be tested for the different genes, or we test through the blood through a new technology, and this is how we detect whether you have the gene or not. We talked about psychological evaluation. Now, so after you're done with your early treatment, so within those 5 years, it has been shown that if you're physically active, all right, if you have a healthy diet and you control your weight, that will decrease the risk of recurrence, okay? And basically, you want to think about it as energy drives disease. So the more you store sugar and energy and fat, the more you have adipose, which is fat tissue, and the more this fat tissue is going to produce estrogen, and the more the recurrence of the disease is, because most of these are responsive to estrogen. Alcohol per se consumption within these 5 years does not affect the recurrence, okay? And although mindfulness technique, yoga, breathing technique, all of these do not decrease the recurrence rate. However, it does improve the quality of life. So pregnancy is important. Most people that have this disease can be young, so they want to get pregnant eventually. after all of this. So usually we delay pregnancy for 5 years if they are on, on endocrine therapy or they are on trastuzumab. Okay? Trastuzumab is a contraindication, so you should be on contraception when you take it, and at least for 7 months after the end of the treatment. That usually ends within the 1 year, 2 year. But tamoxifen, if it's there and it needs to be taken for 5 years, that's basically putting you in quote unquote menopausal state, then that means you cannot get pregnant. So we have to delay pregnancy by 5 years. And that's why people who are diagnosed with breast cancer, um, because we have to delay pregnancy for 5 years, and if you're around 35, then we're delaying it till 40. If you only count on your eggs, then we know that your ovarian reserve at 40 is going to be very low, and that's why we counsel people to do something about their fertility preservation before doing the therapy, or really after the therapy, and not wait for long. So fertility preservation is something that we should counsel our patient on, and before treatment or after treatment. That's a very important topic, because of two things. Because of the delay, you want to postpone this for 5 years. That's a long time. Second, most of the medication are going to affect the ovarian reserve, chemotherapy, and can put you into a state of menopause that you cannot get pregnant in, and is going to affect that the eggs that you have. So that's why it's important to also talk about fertility preservation, and I'm going to tell you about the options that we have. Now, most women after breast cancer are sexually active, and we want to prevent pregnancy, so we have to be on some sort of contraception. We usually don't like hormones because also breast cancer are responsive to hormone. So most of them we use are barrier contraception, and one of them is the copper T IUD. That's a small T-shaped device that goes inside the uterus, and it's 99% effective to prevent pregnancy. Okay. The other hormone-eluting IUD is usually preferably not to have it. But sometimes with tamoxifen, because tamoxifen is the drug that sometimes can cause polyps in the uterus, can cause abnormal bleeding. We use these for protecting the uterus from endometrial cancer. Now, a lot of people after treatment for breast cancer, they have problems with vaginal dryness and urethral dryness. So they can have symptoms with the urinating, and dryness symptom with intercourse, even without intercourse, just burning inside the vagina sensation. And we also try to avoid hormone in these cases. We try the non-hormonal treatment. However, if these fail, then a low-dose estrogen cream inside the vagina has not been shown to increase recurrence, but it has to be a very good discussion with the patient and with the oncologist. A very important aspect is bone health, because also a lot of the medication puts you into menopause. That means you have the risk of losing bone density, and we have to screen for bone density after the treatment for the disease, and as long as you are on these medication that puts you into menopause. Now, another important fertility issue is fertility preservation. Okay? Fertility preservation, because chemotherapy is going to affect your eggs, then you have the option to opt for fertility preservation before you go through chemotherapy. But that has to be expedited, and it has to be a consultation with someone who's an expert in fertility preservation, because there are certain drugs that we cannot give the patient that are estrogen based. We have to give them other drugs. But that's something that people need to think about, especially if they're young and they don't have kids, that fertility is going to be affected. So there are a few things you can do. You can freeze your eggs, or you can actually, nowadays, they can take a piece of your ovary and freeze it as it is, so you don't go through the cycle of freezing your eggs. And then when you're done with your treatment, they can take that piece of ovary and put it back and plant it inside your pelvis. And then you can have a natural child. The last resort is someone who's lost their egg reserve is to basically have egg or embryo donation. Okay, so these are protocols for what to do with the egg preservation protocol to see what kind of ovarian stimulation to do. I'm not going to go into the details, but basically we have different protocols, especially for cancers that are responsive for estrogen. So these are the major things to keep in mind and to be aware of. And my final question, my final thing I want to say, always, always in these kind of hard situation, a multidisciplinary approach is the best approach. You need on board your psychiatrist, your psychologist, your oncologist, your gynecologist, and your general surgeon for one type of this disease, because every decision along the way needs the opinion of all of these together. Thank you.
Thank you, Doctor. Indeed, it's, you know, so many things, and obviously a life-altering journey, I would say, after exploration. So, but at the same time, you know, as we're listening to you, I feel that if it's gonna happen, it's gonna happen. The sooner we detect it, and the more knowledge we have about that journey, it just feels more, I guess, you know, empowering to have that information on our side. So thanks for the info. We have actually a lot of questions. I'm gonna start with, so we had questions around how can we detect the genes. I think you mentioned the genetic testing. I guess there are so many solutions today in the market. I don't know if you want to add something specific to that question.
So for gene testing, usually it's done on the person that has the tumor. You can test the tumor itself for genetic diseases, or you can test by blood the person involved. And if the person involved is positive, then we can test the family members. But what you need to know is usually with BRCA1, BRCA2, they are autosomal dominant. That means they usually don't skip generations. So every generation will have individual females that are affected by the disease, and sometimes male also.
So are we saying that testing would happen after detection? So you're not with preventive testing?
Yeah, no, I am with preventive testing, but we don't test everybody. So people who are candidate for testing are mentioned here. So if you're high risk from history only, okay, if you have history of ovarian cancer in your personal history or a relative, then you're a candidate to test for for BRCA1, BRCA2, and the other genes. History of breast cancer in a relative before 50. If you have multiple relatives with breast cancer, history of a male with breast cancer in the family, or history of bilateral breast cancers. So these will put you in a high category as just history-wise. And this is where we say, why don't you go for testing of gene testing?
Yeah, okay. And I always have, you know, that question when it comes to relative, because I know we often look at the mother side. What about the father side, the aunt, let's say below 50 who got it? Would the woman be at risk too?
Yes, it's actually this is a very important question. Both sides are at risk. So males usually carry the gene, but they don't manifest it because it has a lower rate. But if you have aunts from the paternal side that have the disease, that means it is running in your family. So you have to always look at both sides.
Great, thank you. So what about, okay, let me proceed with the questions from the audience. So Chantal is asking, we have, if the mom she has breast cancer, she has a survival of breast cancer, and she was diagnosed in her 40s, and she's 32, So do you recommend she starts screening from now? And also, do you recommend that she does the gene testing? I think you
So
answered
if
this already, but to answer Chantal.
if the mother has been tested for the genes, okay, and she tested negative, then we don't have to test the daughter, Chantal, okay? I'm gonna address Chantal straight. So if your mother has been tested for these genes, then it's worth looking at those before deciding whether to test or not. Also, having your mom with breast cancer puts you at a high risk even if you test negative for the genes. The only difference between both
Yes.
is if you do the gene testing and you decide that the gene will only tell you whether you want to have a decision at around 35 or 40 to have a mastectomy or remove your breast and put implants. If this is a no-no for you, then I think the gene testing is just going to give you more anxiety about the disease. So some people, that's why some people choose not to test for it. But of course, if you're someone who likes to know whether you have the gene or not, then testing is easy these days. Um, so to answer your question, yes, you should start screening. The screening is going to be a little bit different for you because you are 32. Probably screen with ultrasounds, no mammograms for now. But yes, it is a good thing if you start screening.
Great. And you mentioned something, Elias, very important, which is something that we always forget about is that I think out of the people who get breast cancer, correct me on the number if I'm wrong, maybe 8 to 10% are gene carriers, right? And the
Yeah.
rest are just sporadic and we just don't know how it happened.
100%. That's why they put this Gale model algorithm that depends on your lifetime risk. Okay. So if you're more than 20% lifetime risk, that puts you at a very high risk, and they have a different screening modality, alternating MRI and mammograms for these people. With a Gale model of less than 20%, um, then you're intermediate risk, and then you have less than 5 to 10%, you are low risk. So yes, very important. You don't have to have the gene to be high risk. So family history per se can just put you at high risk. And better be safe than sorry. That's why we have all these screening modality to make sure that if you have a disease, it will be a very early one.
I just saw that it was your first point on the slide. So
Yeah.
yes, absolutely. So the probably the genetic part is the last of the indicators. It's a whole combination of elements. Great. Okay. So I'm gonna keep going with the questions. I'm a post breast cancer surgery. Maybe she's going through it, and BRCA positive. Should I go for double mastectomy?
I'm sorry about the news. I hope you get better very well and soon. Um, in my opinion, yes, you should go for a double bilateral mastectomy, yes. Because the chance of having breast cancer in the other breast is going to be high, and that's why I think you should do that. The other thing you want to think about is when you're done with your breast cancer, you want to think about ovarian cancer. Because with BRCA1, the risk of breast is around 60 to 70%, and the risk of ovarian is around 40%. And BRCA2, it's around 40 for breast and 20 for ovarian. So really, if you're done with childbearing and you don't want kids anymore, then your post breast cancer treatment, you can opt to remove your ovaries also to drop significantly the risk of ovarian disease, which is also a quite common disease in women.
Just telling you that she already did she removed the ovaries too.
Oh,
So
okay. All right.
Thanks, doctor. What about, Elias, the other cancers that would a person who had breast cancer history could be at risk? Like, is there any correlation? Do we know from the evidence today what is the prognosis of other diseases?
So mostly with BRCA1, BRCA2, that's what we know, okay? We know that there is a list of other cancers that are high in these diseases, okay? But most notably in BRCA1, BRCA2 are breast and ovarian, okay? There's another one called Lifromanie, and it has a big list of diseases that is associated with it. There's another one called that comes breast and gastric cancer. Okay, this is related to a gene called CDH1. There's another one associated with stomach, polyps, and breast cancer. Okay, many other are associated with benign tumors of the body and breast cancer. So really, and then some other diseases are associated with colon cancer. So really, it depends on what genes we are targeting there to have these diseases. But sporadic, which is the most common, sporadic breast cancer per se, is only breast cancer.
Yeah. Trying to sort through the questions. Okay. So I have maybe want to add on since we are on this slide, based on the history, if you are at high risk because of the second factor of the algorithm or this whole equation, below 40 should, as a preventive measure, the women also do mammogram or ultrasound is enough?
Usually we don't like to do mammograms for people who are 35 and below, and question mark between 35 and 40 because of dense breasts. So the breast changes in nature when you're young. It is more glandular and less fatty, and then with time it becomes more fat, less glands. And that's why the mammogram, when you have a lot of glands, it is just you don't see anything. You don't see the lesions because they're going to be obscured by the glands. That's why we resort for an ultrasound. And in some people who have even in ultrasounds, we cannot see anything and they are high risk, we go for MRIs, which are the best imaging for the breast. But yes, usually below 40, we resort for an ultrasound that would show us a little bit more than a mammogram.
Yeah, and then if there is more to investigate, obviously follow-ups can happen. Okay. So you talked about the egg freezing, the preservation of the childbearing, the reproductive capabilities, if you want. So does either the cancer or the treatment, based on what you know or what we know, affect the quality, let's say, of the eggs or the ovaries, or in general the uterus and its ability to be to have that childbearing abilities and maybe abortions or whatnot?
Yeah.
How does it impact?
Per se, chemotherapy done for breast cancer purposes is not associated with malformation of the baby. They usually do not affect the uterus itself because it's not a mechanical thing. What it does is when it goes into the blood, okay, it circulates and it reaches the ovaries. The ovaries are very sensitive organs, especially the eggs in the ovaries. And women are born with a certain number of eggs. They have a pool that they cannot change. It's not like men. They can filter sperm and produce more sperm. So you have only these eggs. And then when you have most of these chemotherapy regimen, okay, are cytotoxic, which means they're gonna kill these eggs, okay? And this is where infertility comes in. So people with, let's say, a good reserve of eggs after chemotherapy might have a very low one, because many of these eggs are going to just simply degenerate and die because the chemotherapy is toxic to them. Okay. And that's why we're recommending that if someone doesn't have kids, they're very young, okay, to at least have a thought about their fertility before they jump straight into um, to treatment.
Thank you. Very helpful. We're gonna go back to a maybe even earlier stage question, and it's a very, we forgot maybe to address it. Somebody's asking, what are the basic symptoms for finding this cancer?
Yes. So most cancers are asymptomatic. That's the thing with breast cancer. So you will not feel anything. It's just they pull up as a mass or a lump inside the breast. Now, the thing is, breasts can be lumpy, you know, they have glands in them, they go through a lot of changes. So really, it's hard to know which is a pathological lump versus a benign lump. And that's why we are very aggressive in how the way we deal with lumps, okay? Or we deal with breast per se. So anyone who has breast pain, what whatever the reason is, they might have um, chest pain from the inside, they might have cartilage pain, they might have a muscular pain, anything, any pain in the chest area that is around the breast, we take it seriously. Okay. It might be a pulled muscle, but we take it seriously. Okay. Um, anyone who has a lump in the breast that they feel that wasn't there, or they feel something weird in their breast, then we take it seriously. They need to be checked. Anyone who has a lump in the armpit area, okay, or around this area, then, or in the midline, or around the breast, we also need to check this out. Anyone who has pain in the nipple area needs to be checked out. Anyone who has a discharge from their breast needs to be checked out. Anyone who has a skin redness in their breasts also need to be checked out. So all of these can be sign of cancer, but all of these can be just normal stuff, right? But because it is very common, we evaluate aggressively. That means don't take a chance. If you have any problem happening in the breast area or in the chest area from the outside, get it checked out. It's only an exam in clinic, and then the physician will guide you what to do.
Thank you, Elias. I'm coming to visit you soon. You know that, right? After this
Welcome.
Okay. So we're getting, thanks guys for sharing. We're getting a lot of stories of women who have gone through breast cancer, who have, you know, undergone surgeries of different areas. So thank you for sharing with us. Also, someone is asking, how do we recover from this? Like, I'm not sure how we want to address this question, but I also think it's a great question. Like, do we
That's
recover? Are we always worried the post breast cancer? What do you feel about this?
um yes, I mean, any cancer you get, you have this recovery period or the within 5 years recurrence rate. And this is where your mind is always there thinking about what if I'm gonna get it again, okay? That's why the most important thing in these situations is to have this multidisciplinary approach that can really um, embrace you and tackle the issue from different angles. Because we cannot do it on our own. We need multi-professionals to do this for us. For example, I see a lot of patients post breast cancer for their care after breast cancer. Okay, I collaborate with an oncologist that he takes care of their medication and their chemo and all of this. We collaborate with a general surgeon that have done their surgery. So it's a chain of collaboration together, and we keep on every visit, talking to each other to just make sure that all the angles of the care is really well established. Also, we have our psychologist and psychiatrist that is on board. This is a very anxiety provoking um, disease. So post cancer, you have a lot of anxiety involved, and we need to address this. There's a lot of, sometimes depression involved, and we need to address this. So really, do you ever recover from this? Yes, but it takes time. Because the treatment is for a long time, then I think you basically adapt to it, but eventually it ends. A lot of people are cured and are survivors from breast cancer. We have a lot of people. And today, with our early detection, we really are dropping the incidence of, uncurable breast cancer. So yes, we do survive after this, and with a team that is always with you. That's how you survive. And there's a lot of problem that entails the treatment, as I mentioned in my lecture, like bone loss, vaginal dryness, symptoms of menopause, um, things like contraception that you cannot take. People want to get pregnant. When is the good time? You need professional opinion about that. Don't just uh, seek help, because it will make your life way easier. And we have to stay positive. You will get over this.
Yes. It's a journey, as you're saying, Elias, and I think it's always tough because it's a disease, that impacts life, right? Like the sooner, obviously, we detect it, the higher the chances of survival, like you're saying. It's a journey. I mean, I don't like to compare cancer to any other treatment, but I've also been, and I've seen people go through different types of diseases, let's say, and it's always this journey. And I love your point around the multidisciplinary approach, because you need, yes, your direct healer or caretaker, but you also need this whole group of doctors around you. You need family members and friends, and you need mostly to be, not so tough on yourself to expect the recovery to happen maybe the next 3 months or so. So maybe if I go back to this whole journey, obviously the ultimate part would remain the prevention. And here I want to maybe pick your brain with, I don't know, we have one last question, but before that, we know a lot about healthy lifestyle, and you even mentioned it after the incidence of the disease. But before the disease, healthy lifestyle. Recently, we're hearing a lot about how alcohol consumption affects maybe the risk from a lifestyle perspective. What are your thoughts there, and what do you recommend?
A healthy lifestyle is always a good thing to do, okay? Um, I mean, food, smoking, alcohol, all of these are very common in our society. And it's, you know, if you have a sedentary lifestyle, then your risk of all cancers will increase, including breast cancer, okay? Because cancer is a cell also. It is like our normal cells, okay? So it is driven by all these calories that we give it, all the sugar that we give it. So the difference is these cells, they just multiply way faster than our normal cells. So the more you fuel them, the more um, you're gonna let them grow. And the more you starve them, the more you're gonna impede their growth. Same principle applies here. If you're gonna sit on the couch and eat junk food all day, then you're fueling any abnormal cell to multiply. But if you are exercising, keeping a restricted calorie a healthy BMI, then you are not fueling these cells to actually grow. And that's the theoretical way of thinking about why a healthy lifestyle helps you with that. Now, smoking is linked to many other diseases. Many people don't know that smoking causes bladder cancer because they would say, why is smoking causing bladder cancer? Because all these toxins go into the blood and they're filtered in the kidneys and they go into the bladder outside the body. So, alcohol is also linked to many cancers. We're not only talking about bladder here, we're talking about head and neck cancers, esophageal, stomach. These are all cancers that actually are happening, but we don't have screening ways for them. So really, breast cancer, I mean, it's a bad thing to have, but at least we have methods to prevent them from, having a big effect on our life. So it might just be caught up like a normal disease very early, and then we can get rid of. So really, if you want to have, I don't mean it this way, but I'm going to put it that way. If you really want to have a cancer that has a screening way, because you will have it early. Okay. Most other cancers don't, you cannot screen for them, and they're only caught when they're too late. Okay. That's why
Mm,
we're having problem with screening for ovarian cancer because it's so hard to screen for.
mm,
So really, in some way, I think it's a good thing what we've done about the screening. Don't let finances impede your screening. We are having right now, everybody in the country is having Pink October. Here at
mm,
CMC, you can have your consultation, your mammogram, and ultrasound for only 400 dirham. So really, I mean, this is nothing for what you're doing for your health. So you're preventing a lot of, bad experience for only this amount of money. So I encourage everybody, if you have insurance, if you don't have insurance, there are many ways for you to screen, and don't neglect that.
mm. And don't be afraid. A lot of people, as I will start from myself, right? So we're afraid of detection in the first place, but then always the thought, okay, if it's there, it's there, nothing, you can't do anything about it, so better catch it earlier and deal with it. This is, I guess, always the fear of, behind the taking action if you want. And to your point, I think a lot of awareness, the reason maybe a lot of awareness has started to happen since maybe the early 90s around breast cancer is because it is detectable, because we are lucky we found a way to detect it. So speaking of detection, we have a question. Also, I love these questions where they tackle everyone. What are the best ways of self-examination? Maybe frequency,
Yeah.
where you recommend people do it.
So basically, so when I started my training, the American College of OBGYN used to recommend self-breast examination. So basically, one can examine their own breast. However, they've seen with the trend that it caused a lot of anxiety because
Mm,
people really, I mean, anything they feel, they can feel that this is a lump, right? So at some point, they also recommended not doing self-breast examination and go and have a clinical breast exam every year. So for less low risk people, really the only thing you need is a breast exam, is a clinical breast exam by a specialist every year, and that will suffice. So anyone who comes in for a pap smear, for an ultrasound of the pelvis, I usually give them a breast exam. So that will be part of your screening. So you really don't have to be self examining yourself all the time. Of course, if you feel something weird, then
mm,
you have to check it out. But really, self breast exam
yes.
is not recommended anymore.
Mm. Yeah, I mean, yes, to your point, maybe it's a nuanced answer. Obviously, it doesn't hurt to always be self-aware, whether
Yeah.
physically, emotionally. It's just maybe not to um, obsess too much about it. But I'm a big fan of being self-aware, even physically. Like I always say that nobody will know you more than you know yourself. I mean, you gotta feel something to go to the doctor, right? The doctor will not know. But maybe from a clinical guideline perspective, on a population level, um, going to the doctor on a yearly basis is probably like the clinical recommendation, as you're saying.
For my high-risk patients, I usually teach them how to self-breast examine, okay? But I don't
Yes.
teach everybody. Low risk, usually they don't need it, but for high risk, I usually teach them how to do it, yes.
Yeah. Yeah. Okay, there is a question about vitamin D, and I've heard that before. So I think it's important. The levels of vitamin D, if they are low, whether they are correlated to having breast cancer, and for the survivors also, what is the role of vitamin D post breast cancer in prevention of future diseases?
Again, we have to really look at I mean, I don't want people to focus on in general that, oh, if I have vitamin D, oh my God, I'm gonna have cancer. That's what I don't want. What I want people to know that everybody should have a vitamin D level checked, okay, on a yearly basis. We are all deficient in vitamin D. It's a very common deficiency. So in general, low vitamin D is not good for health, okay? And yes, there are few reports that are saying it could be associated with breast cancer, but it's not a causal relationship. Not everybody who has low vitamin D will have breast cancer.
Mm,
So that's why I want people to think about that. But I want people to know that vitamin D is very important for your bone health, for your skin, for a lot of things in your body. So that's why we shouldn't be deficient in it. And with your annual exam, checking a vitamin D is not a bad idea. And if you're deficient, replenishing vitamin D is also a good idea.
yeah, I love this holistic approach, not fear-driven, but holistic-driven because you care about your health. Okay, I think we have. So, by the way, I discovered maybe 5 minutes ago as you were talking that we had 13 unanswered questions, but I tried to, I think, address some of them. We have 5 more minutes. Let me see if we have any questions or if someone wants to ask in this time. Okay, I'm gonna ask also a very generic one, and I think we will maybe wrap up with it with a final word from you, Dr. Elias. So, does contraception increase the risk of breast cancer?
Um, yeah, that's a very important question. Is it from the audience or from you?
It's from the audience, from you,
Okay,
sir.
so listen, for high risk people, I don't recommend contraception. Again, depends on the risk. For low risk people, there is no study that has shown a correlation between taking birth control and breast cancer. So if you want a clear-cut answer, no, there is no link for that. However, because high-risk people, we try to minimize everything that is linked to breast cancer. That's why we would not recommend it. However, there are other types of birth control that you can take that do not include estrogen in them. And like a Mirena IUD, like a progesterone-only pill, like the Nexplanon, which is an implant that goes into your arch. So contraception should not be stopped because of the fear of breast cancer. If you still do not want to believe that they don't cause breast cancer, because this is very common belief, then you can take something without estrogen. Now, why? I'm going to explain why this is a common belief with everybody. Because the biggest study on hormone replacement therapy, not even birth control, okay, on hormone replacement therapy on women that were above 65 showed that only women above 65 that has taken hormone replacement therapy have a slightly higher chance of breast cancer. But when they controlled it for age, okay, it has been when they controlled it for age, they've seen that it was age that made that difference, because age is the biggest risk factor for cancer. So really, it's not hormone replacement, it is age. And hormone replacement below 65 can have a very beneficial on the heart health, brain health, bone health, and a lot of other health. So, but per se, birth control pills, which are a different concentration than hormone replacement therapy, have not been linked to breast cancer.
Great. So unless if you're high risk, keep doing what you're doing, I guess. Okay, I think with that, maybe we still have questions, but to be respectful of the time of everyone, the last comment maybe I have, we had a lot of questions around whether this is being recorded and it will be shared. Yes, this session has been recorded, and we will share the recording with you after that. Maybe my last recommendation is always keep an eye on yourself, on your body. Check in with breast and other areas, you know, the regular screenings, the blood screenings, the blood work, and of course, go see Dr. Elias or your medical provider, you know, to if you have any doubts or even for preventive purposes. Elias, I give the last word for you. Thank you so much for so much insight for today, and I will leave it for you to wrap it up.
Thank you for having me. It was a pleasure having this session. I encourage everybody, please do not hesitate to go screen yourself. Or if you're not sure whether you need screening or not, just ask your gynecologist or your physician, and they will be able to guide you. Screening is not a cumbersome process. Most ultrasounds are done, they're not painful. You just sit there and it's like doing an ultrasound for a baby. So really, it's not a cumbersome process. It takes you less than an hour and to get your breasts and health in check. So you are welcome to get any package you want. There are a lot of packages in the country, and I would say take advantage of these packages because they're gonna expire end of October. So if you don't have insurance, use the packages. If you have insurance, it's all covered by insurance. And I hope this was clear. And if you have any questions, I think at some point Nancy has my number. Anyone who has questions, they can feel free to ask them. Okay?
Yes, I do. Thank you, doctor, and thank you, everyone. And stay safe. Bye.